Hello, I'm Jane Dolphin. I'm an occupational therapist and a movement and handling trainer, and I am going to talk to you today about an OT journey supporting care homes across Kent. This was a project funded by KCC, who commissioned OT for Independence to provide this OT service into residential and nursing homes. To put the project into a little bit of context, we have an ageing population, and with the ageing population, we're expecting a greater demand on our services in health and social care. Newcastle University published a report in the Lancet, and they're expecting 446,000 over 85-year-olds to require around-the-clock support by 2035. And for the over 65-year-olds, they're expecting the current number to rise by a third to approximately 1 million people. All our services are pretty maxed out. We don't have much wiggle room, so that for us to pick up extra cases, or if there's a surge in cases that clients that we need to see. So we need to be thinking about different ways of working. And over the years, there have been certain initiatives such as Invest to Save projects, where actually there's been an emphasis on training staff, working with our key partners and training those, so the social care staff and our informal care agencies are following the same moving and handling techniques, and they have the same equipment available to them, so they know how to use these more expensive manual handling systems in the community, and working with them to look at how we can promote single carer handling, because our carers are like gold dust. We have a lack of hospital beds. We have a lack of carers available in the community. It's hard to get people onto enablement services. Everywhere it feels jam-packed, so it's about freeing up those resources and working a bit differently. So the things that KCC had already been providing was, for a number of years, they have been providing single carer handling training to domiciliary care providers, investing in better moving and handling equipment, which can reduce the number of carers required or can maximise someone's independence. But we still hadn't really been engaging with the care homes on how we could incorporate some of this better equipment, different ways of working, single-handed carer techniques into the residential and nursing care homes across Kent. So when we started the project, we were in a very fortunate position that we came bearing gifts. We had been given sets of ETAC slide sheets and multi-glide gloves, slide sheet gloves, and some Samsara Steadies to identify the care homes that would benefit from this equipment, train them how to use it, and provide them with it. So that helped in our initial engagement with the care homes. That helped us get over the threshold. But I don't think the managers or the care teams knew enough about what we could help them with and support them with. And actually, at the beginning, we had an idea generally of areas that we thought OT would be of benefit within the care homes, but we didn't really know have it what they actually needed from us. So we had a leaflet outlining all the different services that we could support them with, or the assessments we could offer, and we were offering a moving and handling service and support, and that included individual assessments, resident-specific assessments, but it was also reviewing their current documentation, risk assessments and moving and handling plans to ensure they were fit for purpose and would meet all legal requirements of them as a safe system of work. We were offering support around falls within the care homes, and that could have been general advice, and it could have been environmental audits as well, or making minor adaptations. And I think for some of the care homes, they had huge amount of data that was collated, and they'd been keeping incident reports, falls risk assessments, accident reports for when someone had fallen, but it was about having the space and the time to then review that all as a whole, and apply it to that person. For example, a gentleman who's mobile, independently mobile with a frame, living with dementia. He was having quite a lot of falls at the evening and later on of night time, and from the observations that we made of him, and from all this wealth of information that had been kept by the care homes, we were able to identify this gentleman is sundowning, and he's getting really anxious around that time, around early evening, tea time-ish, 4 o'clock, that about where he's staying that evening. So from that, we could put into our plans about when we started supporting him to know where he was going to be that evening, to try and help him feel safe. What language at different times of the day we needed to use, and maybe how many carers we needed to use at different times of the day to be able to support him. So it was about analysing and reviewing that data that often the homes will keep about the falls. We were offering support with aids and adaptations, some ramping or new types of equipment. We looked at seating assessments and positioning with the bed to try and reduce pain and detrimental body postures and positions. And we spent time with activity coordinators, and we're trying to embed meaningful activities throughout the whole of the day, rather than just the activity coordinator being responsible for that. But it was about how we could try and match the how we interacted whilst we were giving support, and how we could involve people in that support, and at what level we needed to pitch someone's engagement with an activity. And we used the Royal College Authority's Living Well in Care Homes document. That was very useful. It's a huge resource, and it has resource for the staff, for the managers, for the families, and for the residents, on how you can live well in care homes. And we were supporting people with how they could best manage challenging behaviours. We we would be using kind of ABC charts, but rather than antecedent or for the A as what was going on or what was the trigger that started this challenging behaviour, we kind of reframed it so that it was activity, behaviour and consequence. So we could see when someone was positively engaged as well as being seen as negatively engaging, to give us a better overall picture. So after a few months of working with the care homes, we set out to get more feedback from them about what they actually would like in the support that we could give them. We asked them to put their top 3 out of a list of what they found most beneficial or would like in the future. And they really liked the provision of moving and handling equipment. That was up there. The practical skills workshops that we were delivering to the staff teams were found to be beneficial. The individual resident assessments and recommendations were well liked and well received. But it also led us from that feedback to look at developing further workshops around moving and handling of people living with dementia workshops, and risk assessment and handling plan workshops as well. The project ran for approximately 3 years, and we moved away from promoting single handling techniques, which we were doing at the beginning, and we were focusing more on quality of life and improving quality of care. We were able to work with the homes around unsafe handling practices. We witnessed a lot of toileting slings being used inappropriately, and in quite a few cases, the residents themselves were advocating the use of toileting slings because that make continence management so much quicker and easier. So it was working with them as well about finding suitable alternatives, different types of slings, different type clothing, and educating people about why it's high risk and why it's high risk for the client and why it's high risk for the service user. Same with drag lifts. If we witness some drag lifts across the county, and we work with the manager as to then educating the staff teams around why that was a high risk technique. Slings were often shared around the home, so you were expected as a staff member to go to a cupboard and find the right sling, except a handling plan wouldn't be in the client's room, so you weren't always sure what sling you were supposed to use, and they didn't always wouldn't have met the lower standards because you couldn't read the label, and that was so important, and to explain what needed to be in a handling plan, what was the really important detail that carers needed access to there and then when they're going to support someone with hoisting, because it's often, if an incident or an accident happens with a hoist, the evidence has shown that it's often that the wrong sling is being used or the wrong loop configuration is being used, and it was just educating people around that. We did think that, are we just doing these handling assessments and providing people with risk assessments and moving and handling plans? So as well as providing those to the care homes, we provided them with the paperwork and worked with key people in the home if we could as to why that level of detail was needed in handling plans and the risk assessments and the whole point of the risk assessment. as we wanted to prepare the care homes to be doing these assessments themselves, we also provided via KCC, funded via OT for Independence, to train the trainer 5-day courses for the care home staff, which was very successful. The mandatory training for new starters was provided on Zoom when we went into lockdown, just so that we were able to carry on supporting the care homes and that they could carry on having staff who were able to handle people safely. And then we started to provide yearly updates for their moving and handling training on Zoom across to the care homes. And we began to work a lot more around positioning and 24-hour postural support for people. We kind of started with positioning in wheelchairs or seating, and then the importance of that 24-hour postural support became really evident. But we worked a lot with Simple Stuff Works, who have a great set of equipment. They were doing all their assessments via Zoom as well, and if they would never sell you anything that wasn't needed, and often they said, well, we could use this, this and this, but their support was invaluable. But we began to realise we hadn't asked to see people who were becoming quite immobile and developing detrimental body postures and high tone, and the managers didn't really know that was a thing, because you don't know what you don't know, that there was a thing to be doing. We started doing a lot more work supporting people living with dementia, so we used PALS checklist for a while, but and that we were able to engage with the family, and we got really lovely narratives from some family members, and then we could tailor that to people's likes and dislikes and sensory experiences that they might like to do, because some people weren't able to tell us. But also supporting people living with dementia and sensory and proprioception difficulties or deficits, that also fed into very much how we would position people living with dementia and how we needed to handle people living with dementia. The OT service that we were providing began to be incorporated into post-abuse safeguarding plans. I'm not sure if that's the correct terminology, but if a safeguarding concern had been raised and an inquiry made, then sometimes the recommendation was that we would carry on working with the home after the inquiry had finished, which that I'm a believer that in these settings, people don't go into work to cause any harm or to do a bad job that day. And so that was quite nice. At the end of an inquiry, you actually got support after going through safeguarding inquiries. And we developed links with the commissioning service, so we could begin to share our information that if we had any concerns or we thought a home needed support for one reason or the other, we could speak to each other and prioritise those homes. We need to mention how we worked, as I think our working styles changed over the time. We had to be very flexible because the care homes are really, really busy and are busier at certain times than others. So in the morning, the staff teams, the care teams are supporting people to wash, to dress, help to support them to eat, to do the moving and handling and the hoisting, and so there's a lot to do in the morning. So sometimes we would work a shift. As they work a shift, the carers I work with probably didn't think I did a true shift, but maybe like go support from 7 to 12. So I'd arrive at the care home at 7, and I would be the second hands or the second carer for people who are requiring double-handed support or had complex handling needs, and we would complete the personal care, which would be washing, dressing, sling fitting, hoisting, positioning, with the residents' permission or their significant others' permission and the carers, which was really important, I think, because if we're carrying out a moving and handling risk assessment, we have that carer section in there, firmly in there, and if we as a profession just focus on, in a care home or in a dom care setting, on that one that resident specific assessment, then we're missing that the recommendations we're making impacting on that carer are for that call, but they also will be doing lots of other moving and handling from that moment on. So that was really useful to be able to really get a feel for the resident within that risk assessment, but really get a feel for the carer as well, of what it was entailing. We were supporting people throughout the pandemic. We had PPE, so if necessary, we would go in, and it was more remote working because they were on lockdown as well, and there was a high risk of us passing on any infection. And there was a lot of emotional support during that first lockdown, March and April as well. We were phoning care homes, making sure they were okay, knowing letting them know that the training was still available for their new starters, and providing links on proning, how to prone someone, and where to access PPE, because PPE was really short at that point. So I just wanted to finish off with our key findings, both positive and negative, and possibly where future projects like this could, what they could possibly develop into. So good communication and collaboration with the manager of the care home was essential. The ongoing support and that we were able to do during the pandemic was much easier with the managers that we'd established a good working relationship with, and implementing what we recommended, and letting us be involved as part of the care team, was all dependent on that good communication. The funding of equipment and our recommendations of equipment not being followed up, and a batting of that's not our responsibility, that's social care's responsibility, that's health, not so much health, but usually between social care as the commissioning service and the home itself. But as we developed the service, towards the end, we were trying to find more, not cost effective, but for example, more modular seating that could actually, it wouldn't be just for one resident, but some care homes had a rota for tilting space seating, so that those residents, for part of the day, would be able to sit out of their beds. Across all key parties, us as well, at the start of the project, there was little understanding about detrimental body postures and how they can develop, and the need for 24-hour postural support, and more importantly, when that intervention needed to start. So we would be assessing people with Simple Stuff Works to find them some equipment, but it was too late. The high tone or contractures I had already developed. The people, there seems to be some kind of myth that going back towards the end of our lives into this fetal position is somehow comforting, but it's not, and it's preventable. So actually, towards the end of the project, we were helping people with a Mansfield checklist, which would start to identify much earlier when people would, because of the lack of mobility, would be starting to develop poor postures. And linked in with that, just finished wonderful training on 24-hour postural support with Simple Stuff Works and Born at the Right Time. And there's a gentleman, Jo de Clark, in Denmark, I think it is, who has a residential home, but it's split it into over bungalows, and I think 8 people live in each bungalow. He's written some really powerful work on people living with dementia and the loss of proprioception. So because they don't know where the body is in space, they need a lot more positioning and support. Otherwise, when your brain doesn't know where your body is, that's all it can think of, and that's when we get these high tone postures, so that some feedback of where my body is in space is available to the person living with dementia. He also developed, because of that, and that not knowing where your body is in space, for people with cognitive impairment, he's in the home that he runs, he has developed one-turn care, and everybody has only one carer to perform their support, and they're quite high dependent users as well, and that is around, there's only one turn, and because that rolling, when you don't know where your body is without being supported to get your sensory feedback, can be really difficult. And we are finally, because I'm really running out of time, we need to support the care homes to know who needs that service and who needs that input. Thank you for sticking with the PowerPoint, because I can't be there today. So yes, it's our new virtual working, and thank you. And I'll be here for questions. Thanks.